Assalamu alaikum. I am Aisha Mujahed. I am a third year student in Mosul Medical College. My topic today is about peptic ulcers. I am going to give this presentation with my colleagues Worood, Waleed and Noor Faris, supervised by dr.Elaf. I will start talking about introduction, epidemiology, classification, causes, and symptoms of peptic ulcers. Introduction. In general, ulcer is defined as a break or disruption of the mucosal integrity. Peptic ulcer refers to uncircumscribed ulceration of the gastrointestinal mucosa, extending into submucosa and even muscularis layer, leading to excavation due to the imbalance between mucosal defense mechanism like mucus and bicarbonate secretion and aggressive or damaging luminal factors like acid and pepsin. Peptic ulcer most often caused by the Helicobacter pylori infection or chronic use of non-steroidal anti-inflammatory drug. This picture shows the progression of peptic ulcer. At the left side of this picture there is a normal intact mucosa, then inflammation. After that there is a partial loss of epithelium with a basement membrane left intact. This is erosion. Erosion differs from an ulcer in being partial thickness mucosal defect. And lastly, ulceration that extending into submucosa or deeper into the muscularis layer. Epidemiology. Peptic ulcer disease is a global problem, with lifetime risk for developing an ulcer is approximately 10% for males and 4% for females. It occurs up to 15% of population, and it is common and frequent cause of physician visit worldwide. Peptic ulcer disease leads to treatment of over 3 million individuals and 5,000 deaths in the United States each year. As the prevalence of H. pylori infection decreases and non-steroidal anti-inflammatory drugs increases, the relative contribution of each factors to the incidence of peptic ulcer disease will change. The incidence increases with age in gastric ulcer, while most common in middle age in cases of duodenal ulcer. The peak age of duodenal ulcer is between 30 to 50 years. Duodenal ulcer are 4 times as common as gastric ulcer. The male to female ratio for duodenal ulcer is about 4 to 1, while that for gastric ulcer is about 2 to 1 or less. Now, how to classify peptic ulcer disease? Peptic ulcer disease are classified into acute and chronic. Acute is characterized by superficial erosion, minimal inflammation, and resolved quickly when the cause is removed, while chronic is characterized by muscular wall erosion with formation of fibrous tissue, present continuously for many months or intermittently, and 4 times more common than acute ulcer. Also can classified according to the location into duodenal ulcer in the duodenum, gastric ulcer in the stomach, and esophageal ulcer in the lower esophagus, and duodenum occasionally after surgical anastomosis to the stomach. Lastly, Meckel's diverticulum ulcer. This picture shows the most common site of peptic ulcers: esophageal ulcer in the lower esophagus, gastric ulcer in the stomach, and duodenal ulcer in the beginning of the small intestine. Causes and risk factors. H. pylori infection considered the most common cause of peptic ulcer, and chronic use or high doses of non-steroidal anti-inflammatory drugs that used to relieve pain such as aspirin and ibuprofen also can cause peptic ulcer. Mental stress. Mental stress has not been directly linked to the development of peptic ulcers. However, sustained mental stress in people who suffer from peptic ulcer tend to have symptom worsening. Smoking. Regular smoking is a risk of ulcer development and impairs ulcer healing and increase recurrence of peptic ulcer. Alcohol consumption. Heavy and regular drinking of alcohol predisposed to a higher risk of developing peptic ulcer. Lastly, genetics. People who have family history of ulcers more likely to have peptic ulcers. Now, What are the symptoms of peptic ulcer disease? Sign and symptoms depending on ulcer location and patient age. Many ulcers are asymptomatic, but pain is most common symptoms. Epigastric pain is usually described as annoying, burning, or sensation of hunger. Belching, heartburn, anorexia or loss of appetite, bloating, weight loss, nausea, vomiting, and sometimes chest pain. Also, after GI hemorrhage as a complication of peptic ulcer, other symptom develops as hematemesis. Hematemesis is a vomiting of blood that appear as a bright red or dark coffee ground in appearance. And melena is a black tarry stool. And lastly, weakness that occurs due to the blood loss. And thank you. Now we'll continue with my colleagues.
Part 2, Pathogenesis and Morphology, presented by me, Worood Waleed. Pathogenesis. Multiple factors have evolved to protect the mucosa from normal damaging force, gastric acidity and peptic enzymes, which are necessary for daily food digestion. These defense factors are surface mucus secretion, that prevent food particles from direct attach to the mucosa and protect it from the acid. Bicarbonate secretion into the mucus, that cause neutral pH of the mucosa. Mucosa-rich blood flow, apical surface membrane transport, epithelial regenerative capacity, and elaboration of prostaglandin. When there is disruption of any of these protective factors by H. pylori infections, non-steroidal anti-inflammatory drugs, cigarette, alcohol, gastric hyperacidity, or duodenal gastric reflex, this lead to increased damage or impaired defenses, and this lead to peptic ulceration. H. pylori and non-steroidal anti-inflammatory drugs are the primary underlying cause of peptic ulcer disease. More than 70% of peptic ulcer disease cases are associated with H. pylori infections, and in these individuals, peptic ulcer disease generally developed on background of chronic gastritis. Because only 5 to 10% of H. pylori infected individuals develop ulcers, it is probable that host factors and variation of H. pylori strains contribute to pathogenesis. Factors allowed to H. pylori to overcome mucosal defenses are flagella, urease enzyme, adhesion molecules, toxins. Some of toxins called exotoxins because it releases on the surface of the host cell, like VAG-A, and some of toxins inject inside the host cell, like effector molecules. In picture number 1, flagella help H. pylori to move through the mucus layer and reach to the epithelial cell surface. In picture number 2, adhesion molecules enhance the bacteria to adherence to the epithelial cell surface, and we can see it start to release urease enzyme to convert the endogenous urea to ammonia that neutralize the gastric acid around the H. pylori that help the bacteria for more proliferation, like we see in the picture number 3. In picture number 4, the bacteria start to release its toxins and cause mucosal damage by bacterial mucinase, inflammation by protease and effector molecules, mucosal cell death by cytotoxins. The second underlying cause, non-steroidal anti-inflammatory drugs, and it causes the disease by blocking the cyclooxygenase pathway of arachidonic acid. So it inhibits the COX-dependent synthesis of prostaglandin E2 and I2, which is responsible for almost of the protective factors. So the blocking of prostaglandin synthesis will reduce the mucus secretion, bicarbonate secretion, and blood flow. That leads to mucosal damage, epithelial cell injury, and ulceration. Or by topical irritation and direct epithelial damage, and this is the minor rule. Gastric acid is fundamental to pathogenesis of peptic ulcer disease. Hyperacidity may be caused by H. pylori infections, parietal cell hyperplasia, and extensive secretory response. Insufficient inhibition of stimulatory mechanisms such as gastrin release may also contribute. For example, Zollinger-Ellison syndrome. Zollinger-Ellison syndrome, characteristic by multiple peptic ulcers caused by uncontrolled release of gastrin by tumor and the resulting massive acid production. Here we can see endoscopy image show multiple small ulcer in the duodenum. Cofactors in peptic ulcer disease pathogenesis include cigarette smoking, which impairs mucosal blood flow and healing, high dose of corticosteroid, which suppress prostaglandin synthesis and impair healing, peptic ulcer disease more frequent in individuals with alcoholic cirrhosis, chronic obstructive pulmonary disease, chronic renal failure, and hyperparathyroidism. This image shows summary of peptic ulcer disease pathogenesis. That when there is imbalance between the ulcerogenic factors and protective factors, and when ulcerogenic factors overcome the protective factors due to the presence of H. pylori infections or chronic use of non-steroidal anti-inflammatory drugs, in addition of a presence of cofactors like alcohol, smoking, or using of other drugs. These all lead to mucus layer degenerative and damaging of the underlying epithelial cell. Morphology. Peptic ulcers are 4 times common in proximal duodenum than in the stomach. Duodenal ulcer usually occur near pyloric valve and involve the anterior duodenal wall. Gastric peptic ulcers usually located along the lesser curvature near the interface of the body and antrum. The classic peptic ulcer is round to oval, sharply pointed out defect and hangout surrounding mucosa. The base is smooth and clean due to peptic digestion of exudate. Histologic examination is composed of richly vascular granulation tissue, inflammatory cells, and fibrosis. As we said, ulcer is 4 times more common in duodenum than in stomach. More than 80% is single ulcer. This gross appearance show round, small, clean, punched out, and less than 2 cm in diameter, so it's considered as shallow ulcer with characteristic radiating fold. The microscopical appearance show the superficial necrotic layer and inflammatory cell zones, granulation tissue zone, and collagenous scar zone. Here we have not the radiating mucosal fold from the ulcer. Why? Mucosal folds tend to radiate outward from the margin of the ulcer, result of the fibrosis which occur in the base of long-standing ulcer during the healing process. The gross appearance of gastric ulcer show the characteristic sharp demarcation from the surrounding mucosa with radiating gastric fold, and the base of the ulcer is gryoning to fibrin deposition. This microscopic findings of peptic ulcer show it consists of 4 histologic zones. Number 1, surface inflamed fibrinous debris. Number 2, inflamed mucosa. Number 3, granulation tissue. Number 4, fibrinous scar. Now I will let you continue this seminar with my colleague.
Assalamu alaikum, I'm Noor Faris and I will talk about the third part of our seminar, which include complication, diagnosis and treatment. Now I will talk about the complication. Complications include internal bleeding, perforation and gastric obstruction. The first one, internal bleeding. It's one of the most common complications of peptic ulcer, occurring in between from 15 to 20% of cases when peptic ulcer develop near the site of blood vessels and damaging the wall, causing internal bleeding. The second one, perforation. It means that the ulcer has eaten through all of stomach lining. It occurs in an estimated from 2 to 10% of all cases. The third one, gastric obstruction. In some cases, a peptic ulcer can produce inflammation or swelling and or scar tissue that can obstruct the normal passage of food through digestive system. This is known as gastric obstruction. This occurs in an estimated from 5 to 8% of cases of peptic ulcer. This picture shows the complication of peptic ulcer. Bleeding and perforation of the lining of the stomach And ulcer causes stenosis and obstruction of gastric outlet. Now, diagnosis. The history and physical examination help in diagnosis of peptic ulcer by checks for bloating and listen to the sound and taps on abdominal checking for tenderness or pain. For detection to H. pylori, we do lab tests, which include blood test, stool test, and breath test. Blood test the blood sample to see if the result fall within the normal range for different disorder or infections. Stool test the stool sample by sending the sample to the lab for analysis. This test can show the presence of the H. pylori. And finally, breath test. Test the patient's breath if it has a higher level of carbon dioxide than normal. And this picture shows the procedure of a breath test. To make sure for the presence of ulcer, we do endoscopy. Endoscopy involves inserting a long flexible tube down the throat and into esophagus. A tiny camera on the end of the endoscopy lets to examine esophagus, stomach, and the small intestine and look for an ulcer, as shown in picture. The other procedure, biopsy. A piece of stomach tissue is removed so it can be analyzed in the lab. And finally, CT scan by drinking a solution called barium swallow. That's a thick white liquid called the upper gastrointestinal tract and helps in see of the stomach and the small intestine on X-ray. What are the treatment? Treatment depend on the causes of ulceration will involve first, antibiotic medication to kill H. pylori. Second, medication that block acid production and promote healing. Third, medication that reduce acid production. Fourth, antacid that neutralize the stomach acid. And finally, medication that protect the lining of stomach and the small intestine. And lastly, thank you for watching and listening of our seminar. And if you have any question, please write them in the comments.